My thanks and congratulations to the previous presenters, those who are physicians and those who were not physicians. Very clear presentations. I was also very pleased as editor emeritus of ASJ to see that all of you have published in Aesthetic Surgery Journal, and if you'll forgive the little commercial, the journal with the highest impact factor in all of aesthetic surgery. Wow, we have so many choices. When I started practicing over 4 decades ago, someone walked in with cellulite. I wouldn't know what to do. Today we have so many choices. Then over my career, I started with the knife and thought that that was the answer to everything. And as we've already seen earlier today, incrementally, facial rejuvenation, body contouring, peri-orbital rejuvenation, stop being solely in the surgical domain. The non-invasives, the injectables took over, and right now actually supersede by a factor of 10 the surgical procedures that we do for rejuvenation of the face peri-orbital area. So wonderful to be talking about beauty below the belt. I don't think 4 years ago even I would have known what the term meant. Now, thanks to our chairman, we all know what it means, and we have a panel. So I have a few questions for the panelists. I'm interested to know how you got into this. Was it patient demand? Was it an area that you had a passion for? Or did you feel that you would do better work than others? Or was it a practice builder? So, Laurie, welcome, and we'll start with you.
As a woman, I've been interested, obviously, in below the belt since I was a teenager, because most of us have, issues related to below the belt, and then we have children, and so on and so forth. All my patients have been demanding some kind of treatment for below the belt issues, laxity, cellulite, my entire career, 40 years. So it's exciting that finally, there's a lot of attention being placed on it, both from industry and from plastic surgeons, because the demand has always been here. And we do have great things that we can use. So when we start talking about it, it'll be great.
Go ahead.
Yeah, no, it was interesting because I did my aesthetic fellowship in Miami, so there's no way I could not get into some butt stuff being in Miami. It was interesting. From there, I moved to Austin, Texas, and when I moved there, someone told me, "Oh, what's your specialty?" I was like, "Oh, I do a lot of BBLs, butt stuff." And they're like, "Oh, well, you'll have to find something else because nobody else does that." And it was so wrong, right? It wasn't that no one does it, it's that there weren't good treatments, that no one was doing them, so patients were going elsewhere. So definitely believe in the riches and the niches. I think a lot of people strayed away from it because it was challenging, like you said. A lot of people didn't have good solutions. Patients were unhappy. We all want our patients to be super happy. And I think the lower extremity has always been so complex, so challenging, and that's why you saw so many cool presentations of skin tightening, cellulite, hyperhidrosis. In our practice, I mean, there's so many combination treatments that we do below the belt because I think it is so complex, but I think there's so many opportunities now. I think the opportunities for patients and for practices to absolutely thrive right now is massive.
Dr. Perez.
So my journey has been, I think there's 2 big contributors. One is certainly lineage. And so, I did my aesthetic fellowship with Dr. Grant Stevens. And as we all know, he's a big reason of why we're all in this room. And one of the big mottos with our aesthetic fellowship, and what he would tell me probably at least once a week, is, Justin, it's about more than just surgery, right? And so you take that, you take a passion for technology and just trying to make patient outcomes better, and couple that with demand, right? So you have patients coming in, and as some of the other panelists elucidated, thighs would come up all the time, right? And so we were getting better at face and multimodals, and getting better at breast, and getting better at tummy, but there was always an unmet need. And so we couple those technologies together, and I think it's been demanded by our patients.
Great. Well, when we rejuvenate the face, when we do a facelift, it isn't just surgical. We add fat, we do resurfacing, we do a lip lift, we do an earlobe reduction. And the previous presenters also showed combination therapies, and we saw the great results where they combined two or three different modalities. So we'll start with Laurie again. Do you just do one single thing, or is it a combination to get the best possible result?
Well, it starts with assessment. So not every patient has, mild, moderate, or severe laxity. Not every patient has mild, moderate, or severe cellulite in terms of dimples and waves of irregularity. So it starts out with the assessment, and then each patient's plan is individualized. And it always starts with the skin. The skin quality, texture, tone has to be addressed. And we have phenomenal topicals, which, Dr. Burrow was talking about, that really do assist us in a way that it's miraculous. So skincare is always part of every patient's lower extremity plan. And then which device and which injectable do I use? It depends on the problem. If they have dimples, Avali is the gold standard in my practice. It works, it's reproducible, it's safe. Patients are happy 98% of the time in my practice. In terms of volume, I do like Radius. I think it's very, very useful. I did do a study about 7-8 years ago regarding skin laxity. The problem that I've had in uptake with my patients is the cost, because it's very, very costly, but it does work. So it is helpful in terms of volume and tightening of that fibrous entity that connects the skin to the muscle. It's all kind of loose and lengthened, and so it'll tighten that. But I do combine it with Ultherapy. So Radius and Ultherapy is my go-to for skin laxity, but only mild to moderate. If you're in the severe category, you have to combine skincare, procedure, injectables, cellulite reduction with Avali, but you also sometimes have to do surgery. So which do I do first? It depends on the severity of the laxity. So it's always a combination treatment, always.
Do you do it all in one sitting? Do you do it at separate sittings?
It depends on the patient. It depends on finances. It's very, it's a complicated equation. Ideally, I would do skincare, beginning the, topicals the first day they show up and continue those forever, just swapping out which one depending on the procedure. I would do dimple release when I feel like the skin is completely tightened, because I certainly don't want to do Avali for septa, release, and then tighten the skin and have more septa to release. I guess that's good for Avali, but not so great for the patient. So I like to tighten second, and then the release of the dimples third. If I'm doing surgery, then it's skincare, skin excision, and then I look for what other things we can refine the dimples or the waviness with.
Dr. Franco?
I think it's such an interesting time. We've actually used cellulite as what we call a lead magnet, because especially in the setting right now with the weight loss revolution and people losing so much weight, it's so rare that somebody has an isolated, 2 or 3 dimples. If you get that unicorn 20-year-old with 3 dimples, you better treat them and use them in your before and after in every presentation. But, most people have the skin laxity, the volume loss, and like a couple of the presenters said, organizing that thought, coming up with a treatment plan for them. But the cool thing here is that now that we actually have treatments that work, whether you're talking about Renuvion, Hyperdilute, Radius, Avali, all these treatments are so effective. And when you combine these, it's exponentially better. When I started my practice, all these patients came in for BBLs. I would refer them to our injectors for cellulite treatment, for the Avali to pre-treat them. Now it's almost flipped to the others. I mean, we'll have people that actually fly in from New York, from across the country to get their cellulite. So it's such a big problem. But most people will say cellulite. They have no real idea all they really know is that they don't like the way their butt, their thighs look. And so, it's such an opportunity for us to dictate that whole statement. I think one of the cool, unique portions that you've seen here is that lower extremity, especially butt, thighs, those areas, this is a category where I think that non-invasive is overtaking our surgical options. Other than the 150-pound massive weight loss, there's not a lot of great surgical options for the thighs that's going to make people dramatically better. Now some of the non-invasive are absolutely pretty phenomenal in terms of some of these results that the patients are getting. So I think this is such a unique, pivotal time. And obviously you've seen with the weight loss, you've also seen a transformation in terms of patient desires. We used to have this with facelifts where one, people used to be super tight. Two, people used to get overfilled. Now we have kind of a combination. Same thing with BBLs. We used to be in the conferences where you'd see how many cc's could you transfer to the butt. And now that's gone away. And so all of our patients get some skin tightening, whether it's Renuvion, whether it's something else, some filler, and then set up, because I think it's really more about a form and shape than a volume. So super exciting time.
It's interesting that you mentioned Ozempic butt. I got a text from a colleague in Italy. Hey, Foad, there's a journalist who wants to interview me about Ozempic face. What is Ozempic face? So we're way ahead of the rest of the world. So I also told him there's also something such as a Ozempic personality, but we'll get to that in a minute. Dr. Perez, combinations, what do you combine, and do you do it all at the same time, or do you space them apart?
Yeah, I echo what's been already reiterated on the panel. It's got to be a multidisciplinary approach. It's got to be tailored to the patient's desires. Are they willing to accept the downtime or not? What's their budget, right? And then the road forks from there. As Dr. Casas mentioned, as anything in clinical medicine, starts with an appropriate diagnosis, right? So, and I'll talk to the patient about it while looking in the mirror, right? And say, okay, this is a complicated problem that's going to require more than one treatment, and we're going to navigate this together, and it doesn't have to be all at the same time. I think one of my favorite things to do, and it's the beauty of being in a med spa environment, is to pull multiple providers into the room, right? Patients love that, and they'll say, okay, well, I'm familiar with these technologies, I can employ them, I'm a surgeon, let's get our esthetician in the room, let's get our physician extender in the room, and then we have like a conference with the patient, right? And sometimes ideas will come up in that encounter that if it had just been me, wouldn't. So from the skin perspective, if it's mild skin laxity, I mean, we have technologies like even Skin Tight, right, on the Cyton platform for very, very mild issues. A few select dimples, which I think is the holy grail, and we'll use in our before and afters, and those 20-year-olds I do see in my practice, and I celebrate when they do come in. But if they have more moderate skin laxity, I'm a radio frequency guy. I use the MO platform. I do a lot of Morpheus and Body Tight. I don't think there's a right answer for skin tightening. I think it's what works in your hands. I've been liking the results with thigh Body Tight. A lot of those patients do require circumferential thigh tightening, right? So, it is surgical. The patients do have to be flipped. It does add time and expense to the procedure, but I'll explain. And I think those to them, and when you explain it adequately, I think patients get that. Anything that they can come back and say, my thighs feel less jiggly, that's like a win, right? And I'll even tell them it may not be photographable, right? But patients subjectively are feeling that improved tightness around their circumferential thigh. And then for volume, fat, of course, is our gold standard. Biostimulator wise, I'm a Sculptra guy, so I do dilute Sculptra. I think the results of that are tremendous. I think one of the things we don't speak about enough is the improved skin quality that you see in those patients. They do have to follow through on serial treatments. It is expensive. I'll lay that out from the very beginning. But if you look at the skin quality of a butt that's been treated by Sculptra, it's, yes, the volume improves, yes, some of the texture improves, but the actual quality of the skin is much better, and I do think that's appreciable on photographs.
But I've been blown away what people will spend on their butt and thigh.
100%.
And it blows my mind.
Credit card.
One of the patients that Gato showed earlier, I mean, that patient spent almost $18,000 on that thing. It was important to her as part of her career path and so forth like that. But the idea that something that truly bothers them, I mean, and when you fix their thighs or you fix their cellulite, what has bothered them for years and years, you have created a patient for life. That person will talk about you endlessly because they typically have seen 1 million people. They've bought 1 million things on Amazon or on Prime TV at 2 a.m, that haven't worked. And now you have created this loyalty and this patient base that's going to expand.
See, I think we're all agreed that these are practice builders, and that's what I teach our fellows and residents. Tell them you're not going to go out there and be as busy as those who trained you doing facelifts and breast surgery. Start with this, which brings me to the next question. Do you do this yourself, or do you have practice extenders, PAs, nurses, estheticians doing it?
It depends on which procedure we're talking about. Obviously, I still do it myself. I have a PA and an NP, but the radius and old therapy, I get involved with the planning, and then they do the execution. With surgical options, obviously, I do it.
We do a little bit of both, because a lot of times it's multifactorial. So all the Renuvion I do in the surgery, sometimes tying the butt stuff. It's been interesting. It used to be that I was the main referral source for our injectors. Our injectors now have been the referral source for all of our new doctors, because, they're super busy seeing these patients. They've built up that loyalty, and then they refer them. So it's kind of worked both ways now.
Dr. Perez, which ones do you do? Which ones do you delegate or supervise?
It's a great question. I always tell myself, if one of my patients doesn't know everyone in my practice, then we're doing them a disservice. So my goal, whether they are straight surgery or non-surgical, they should know every single provider in our practice and what they can offer. To answer your question, I'm surgery focused, but being quite busy with surgery, I do delegate a lot of these. So starting, from the top and less invasive, we do use Rasonic in our practice. Are part of, working with the beta and optimizing the protocols. Patients have been extremely happy with the results of that. That I delegate to our esthetician. She's very adept at doing it. She's participated in the studies. She's an expert in it. And there'll be times even patients will ask me certain things about Rasonic, and I'll say she's an expert. She's been doing this since the very beginning. So I feel very comfortable delegating that. I think it's, reproducibility keeps coming up on the panel. It's a reliable, reproducible treatment, no downtime, no bruising, no pain. That goes to the esthetician. And then I have several physician extenders, PAs, and RNs. So that might be something like a skin tight treatment, a Morpheus treatment. Morpheus is done by me if it's coupled with surgery. Body tight skin technologies are done by me. And then Sculptra, I would say, is about 50-50, the biostimulators, because a lot of times those are my existing surgery patients, and sometimes they want to see me. I'm happy to delegate that. So it's a mix.
I'm going to reverse the order. Typically, how long does it take you to treat one patient?
Depends on the technology we're employing. So something like a skin tight on the Cyton platform, that's a quick treatment, several thousand pulses, but it does go quickly with the platform. That will be less than an hour. Something like a Sculptra treatment, that's less than an hour as long as it's reconstituted ahead of time and the syringes are ready and all the supplies are ready. I would say probably one of the more time-consuming treatments is going to be like a Morpheus body treatment. And we tell patients up front, they have to show up, they have to have adequate numbing. That's like a 2-hour plus treatment, right? If you're doing adequate topical anesthesia, that takes about 40 minutes to an hour. A good Morpheus treatment is going to take you 40 minutes to an hour. Photos, right? So that's could be almost a 3-hour visit. Let's see what other technologies am I... Yeah, so it ranges. Rasonic is the one that I didn't touch on. So that it depends how many dimples they have or how many areas of wavy cellulite are being treated. It also depends on the protocol that we're employing. Currently, the protocol is 4 pulses per designated area, which does extend the treatment time. If they have extensive wavy cellulite and dimples, that can be up to an hour per leg and thigh. So that can turn into about a 2-hour treatment. Or if they have focal areas, it can be about an hour. But Rasonic typically is a minimum of an hour, and it can go up to 2. And if the patient is thin, sometimes those patients are a little bit sensitive to the vibration, and you do have to take breaks and so forth, and it can be more than 2 hours.
Dr. Frank?
It depends. If we're in surgery, then most of the time it'll be like an Ovule combination with that, or Renuvion, which is actually a super fast add-on because they're already asleep. From our in-office cellulite or lower body rejuvenation, on average, they're scheduled for about an hour and a half. I'll tell you, 80% of them are combination treatments. So it's pretty rare they're actually doing a single, because we'll to mess numb them. The nice thing about that is it's super efficient, because from just doing either like an Ovule or cellulite treatment to doing either, a skin tightening or Renuvion, Sculptra, hyperdilute radius, the add-on is actually very little time, because the numbing, like like you said, is what takes the longest, and their benefit is huge. And again, right now with the financial times, people are willing to spend money, but they want to know that they're going to get a value from it. And if you can do these combos and package this, it's so meaningful for them, and then you can move them to multiple other treatments. So I think it's kind of cool how you can maximize your time, but you got to be thoughtful about it.
Yeah, I don't really have anything to add. So typically it's an hour for the injectable and energy-based treatments, and an hour and a half, sometimes to 2 hours for Avali because of the photographs, marking photographs and doing the procedure. So that lengthens the time. Not for me, but, for the staff using that room.
Dr. Franco, you said it's a combo. So you tell them that right at the beginning and give them the global fee and tell them how many sessions, how far apart?
Yeah, I'll tell you the thing that made the biggest difference for us, we treated our med spa like our surgery side. So we hired a med spa coordinator, wellness coordinator. We have a treatment plan for them. Even for our weight loss patient stuff, we have a treatment plan we give them when they first start. Here's all the changes you're going to see. Here's the Ozempic face and body treatments. And that way they kind of know the whole algorithm throughout, and we can revisit that. When they come in for like their luxury leg experience is what we call it, we'll have a whole outline. So it's like, here's your issues, just like we would if you were doing a rhinoplasty, facelift, those type of things. And so our injectors are so good about it. And then they'll be like, okay, here's all the things. Here's the 1 or 2 things that are going to make the biggest difference, but here's all the stuff. And then our coordinator will make a treatment package and then helps them move, because it helps with care credit, with all the other portions. Also helps them focus in like, okay, here's what we can do right now. To your point that there's always some budget consciousness, and then here's some things we can do later on.
Anything to add, Dr. Perez?
No.
You tell them it's a combination right from the start.
Yeah, and I think that's the key. As in any of the treatments that we offer, if you're transparent from the beginning, then you earn the patient's trust, and then they get it, right? I think when you overpromise with one procedure and then they come back and then they're not happy and they say, well, you're going to need all these other treatments, they say, well, why didn't you just tell me that from the beginning? So if you lay it all out at the beginning, those patients are very trusting, and we'll give them different quotes and say, okay, this is path A. Here's what the non-surgical is gonna look like. We'll package it in this way. I do think it does factor into financing because everyone has budgets, ourselves included. And all the way through the other pathways with surgery. And we'll give them that on the front end, and then they can decide. And then they have all the information they need.
Quick question for all of you. Laurie, early in your career, it was the breast. That's how I got to know you, and that's what I always thought of you as the go-to person for breasts in Chicago. How did you evolve below the belt?
It's very easy because women that trust you with their breasts, either for reconstruction or anything aesthetic, will trust you forever. So Grant and I have always said patients for life. So besides just doing their breasts, there's always been a discussion about tummies, about below the belt issues. And, for 25 years, there wasn't a lot to offer. So that was the frustrating part. But those patients stayed in the practice, and then they ended up having facelifts and eyelid surgery. And then now we're talking about below the belt. With this new surge and these great options, we can start talking about it right away. So it's really very exciting. If someone comes in for breast surgery, I still give them information in their packet about the body. Of course, why wouldn't you? And the other thing that we haven't brought up, which I think is super important, is just because they do a package and they've gotten a great result, doesn't mean you don't want to keep them in your practice. You have to have maintenance plans and prevention plans from recurrence of the laxity and the dimples. So I think there's a lot of room for education, which builds trust. And that's, I think, how we've kept, my practice, the same patients just stay in my practice from, the age of 20 till they're, 80. So that's great.
Dr. Franco's nodding, so I assume that's how things evolved with you.
I was the opposite, but was kind of my thing when I started there. But to Laurie's point, then my breast business, my other business kind of grew because people trusted. I think a point that they both brought up that was super important is how thoughtful and meaningful they are about pushing people to other services. I think when you think this is just going to passively magically happen, it doesn't. And for the long time, I was the person at every conference just being there, yeah, I'm going to grow my med spa. And then every year being like, why hasn't my med spa grown? But I hadn't done shit about it. And so I think being super thoughtful, purposeful about it is key, and you got to be active.
Okay, final question, and then I have an announcement to make. The final question is, I'm finishing your fellowship. I'm about to start my practice. Tell me 2 things from the list of 5 things that we saw. We saw 2 devices, 1 portable device. We saw creams and injectables. Tell me which 2 I should use if I want to become an expert below the belt. Quickly, 2.
Skin and then Avali.
1, I think owning the below the belt is an easy threshold because you're not fighting every med spa stuff. I think it's a quick niche in the riches. So my take home would be, if you don't have a niche, this is an easy niche. You're not fighting a ton of people. So I would be the expert, talk about it every single day, all the time.
2.
2, man, making it tough, Dr. Nahai. So it would be, focusing on safety and predictability, which I think is at the core mission of the Aesthetic Society. It would be skin tightening and rejuvenation because I think it's safe and predictable, and Avali because it has such great data behind it, and it is predictable and safe.
Well, I do have an
I would do Avali and Renuvia would be my 2 go-to. Avali is a low capital, so if you don't have a ton of capital, you're just starting out, it's a low barrier to entry. I think skin laxity is going to be the biggest issue for the next 5, 7, 8, 10 years. So if you're not talking about skin laxity or treating skin laxity, you're going to miss out.
We're right on time. As everybody knows, the Aesthetic Society is meeting here. The meeting starts tomorrow, and the Aesthetic Society Education and Research Foundation has an annual award. It's a Career Achievement Award, and Laurie Casas is getting that award later this week. It's been fun working with all of you, and Grant, I went over 1 minute.